Do I want my video? Yes. And audio. Okay, there. And then audio. Wait, how do I get back to, I don't know what this screen looks like. How do I get, there's mute. How do I make this bigger?
You don't need it bigger. You gotta have that.
I know, but I want to see
You'll see them.
the controls. Okay. How do I get back to this? What does this mean? I can't hear anything.
Got it. So it was muted right there.
How do I make this bigger?
What are you trying to make bigger? Just leave the screen down because this is what you want to see.
I know, but how do I make it smaller so I can see? Well, okay.
What about this? She's not muted there. Or you want her unmuted.
Well,
Click on
they have to do that though. I can't do it.
Okay, so maybe they haven't joined you.
Okay. But they can hear me.
How do you know?
How do I, because I unmuted myself. How do I unmute myself? Okay, here. It should be on there. Oh my,
What is it you're trying to do?
I can't hear anybody and I
Well,
don't.
they're not there yet, are they?
Well, maybe they are, but I don't know. I
Where's
should,
your microphone?
there's mute.
Speak.
Hello. Testing.
Your device is working properly.
Okay. Let me see if Natalie's on. You have to stay here because I don't know what's going on. How do I make it smaller so I could see the people?
What do you want? What people do you want to see?
That the people that are in watching. Let's see. Maybe do audio there. Service camera. Blur my background. I could blur my background. Do that. Okay. Don't upgrade.
Mirror my video.
Just leave it.
Okay.
I don't know what's going on. No, but I don't know what's going on. Wait. I'm going to try to. Why didn't it share this?
Hi, Kathy. It looks good.
Oh, it does? Okay. So you can see everything?
Yeah.
Let me get this off. Hang on. How come I can't see
What
anything
can't you
else?
see?
I can't see like where's my audio? Like if I wanted to mute myself.
Okay. So make sure your Zoom window is not minimized.
Okay, it's not. Okay, wait, let's see. Okay, it's okay. That's good. All right. Oh, now I can see. Can you see? But I can't see my video.
Yeah, I wasn't able to see myself either.
Okay, I don't want to see myself, but can you see my slides?
Yeah, I can see your slides and I can see you.
Okay. All right. Why can't I see the slides?
Okay, so now if you share what you already are, you can go to PowerPoint now. You can like
Okay.
find the PowerPoint on the bottom, click on it, so then it comes up. Like the
Okay,
little
hold on.
PowerPoint icon.
It was on there. Let me just get back. Let's see more. Share. Wait, just go back to this.
Click on that.
On our end, I see it as a presentation, so you clearly have the PowerPoint up somewhere. Just you have to find a way to get back to the PowerPoint somehow.
Oh, okay. How is it on there? Oh, there it is. Can you see it?
Yay!
Okay,
I can see
I'm
it.
good. Okay, and I can see you.
Yay!
I just don't know how to mute myself, but maybe I don't need to mute myself.
Yeah, I think you're
Okay.
okay for now.
Okay, we're ready. I just see your picture. I don't see you live.
Yeah, no, you don't want to see me live.
Do I need to blur my background?
No, your background is fine. I just see the blinds.
Okay, good. There's Craig. Okay, bye.
Hi. Did you seriously drive? Did you seriously drive back?
Yes,
Oh, oh my
I got too
goodness.
nervous. Plus,
Hi.
it's Wi-Fi here.
Hi. Hello.
Hello. How are you?
Good. How are you?
I'm good. Thank you.
Hi.
So is everything ready?
Everything's
Everything's
ready,
ready.
Thiru.
Good.
Do you see it? Do you see it on your screen?
Yeah.
Okay. And then if I just click on it, okay.
Yeah, you're good.
Yeah, you're good?
I'm good.
Yeah, good.
I'm gonna put a timer on because I talk too much.
I can. You can. You're allowed to talk, whatever time you want to.
As long
So
as
we
you
are
need.
here to you have all ears for you. Yeah.
Well, I hope I have all ears. We're ready to go. I'm excited
Yeah.
about the presentation. This will be fun.
We're all excited too.
So the time change was crazy last time.
Yeah. So that's why I wanted to confirm this time. I was ready by 1 hour earlier so that, there's not be any problem.
Okay.
Almost like one and a half hours earlier now. So it used to be like 9 p.m. there in Houston. It's 9 a.m. in India. It
Oh,
used to be like
good.
that. Exactly
Okay.
9 p.m. and 9 a.m. So now it's 7:25. It's going to be 7:30.
Okay, that's not even the same. Yeah. That's so
Yeah.
strange.
Yeah.
So what time do you want us? We have 5 more minutes.
Yeah, 5 more minutes. Yeah. So that will get more people.
Okay,
Now,
perfect. Hey, Natalie, can you even see me?
I can
yeah,
see
yeah,
you.
You
Yeah.
feel me?
yeah.
Am I okay? Because I can't see myself on
I know.
the
No,
thing.
you're fine. The way the
Okay.
camera is positioned is perfect.
Okay, good.
Yeah.
Okay, we're ready.
But you can click on your right icon so that you can see yourself also in a speaker mode.
Okay, you right click it.
You-
I'm afraid to touch anything because I'm very technically challenged. So,
Really?
so
Okay.
we got this up. So we're just gonna keep going with it. Mhm.
Okay. Anyway, if that's not a problem for you, you can just continue like that, whatever
Okay.
way you want to. Yeah.
Yeah. Yeah. I just want to see make sure the videos play. We tested it yesterday, but oh yeah, they'll play. Okay. Yeah.
Yes, play. Yeah.
Okay. I hope they enjoy it. We love anything related to swallowing, but especially with our genetic kids. It's amazing what we can do to help them.
Yeah. It's really challenging, but as long as you love doing
Yeah.
it, then it'll be easier. And
Yeah.
you can also teach us the techniques because it's very difficult for us to build up a practice even for the normal children. it is even more challenging for syndromic kids because the other issues and everything. We don't have a very specific clinic for them, swallowing and genetic children. So yeah, then whatever you're going to talk to us is going to be good help for us so that we can
Yeah. I
yeah
mean,
improve our
we
practice.
hope that this continues, even after our presentation, because we love to help other people develop their programs. And it sounds like there's
Yeah.
a lot of constraints that you have. You don't have a lot of bottles and things like that. So it's kind of interesting. We were talking about how we can help, and it's kind of interesting. It's a great
Yeah,
combination.
yeah. I mean,
Talent.
yeah, this a great gesture by you people from Houston to have this whole program going on for the past 4 months. I think this is the fourth talk, so this is the fourth
Mhm.
month,
I think
and
so. Next month we are not doing one in July.
yeah. That's what
Okay.
you put in the
Yeah.
group. So maybe we will skip next month, and the next
Yes.
talk will be in August, and
Yes.
then we'll wrap it up in September,
Perfect.
right?
Hmm. I think we do swallow studies and fees. And then I think then the last one is just going to be complex cases.
Yeah. Complex cases and discussion, like case discussion with all of you together. So
Yeah.
we will have a comprehensive analysis of everything, and we get the overall picture of how to deal with the patients and whatever knowledge we have gained so far. So we can apply and see how we can manage.
Yep. I like it.
Anyway, thanks for the time and effort taken by you people to teach us and to build up a program in India. We owe a lot
Abs
to you people.
Yeah. We love it.
Thank you so much. Thank you so much.
We might have to plan a trip, Natalie, right?
Yeah, I mean, you're welcome.
Absolutely.
Anyway, anytime. You're welcome anytime.
That would be great.
Yeah. So I was discussing with Dr. Deepak, about conducting a program here, like proper conference kind of a thing. So he's coming for the conference in this September. So maybe we'll discuss about the next program. When can we do that? So maybe we'll finalize the date and everything so that we
Mhm.
we will invite you all so you can come and share what knowledge, whatever and so that will in a proper program here in India as well.
Right. That'd be awesome. It'll be interesting to see how it goes. That's in September, your first one?
Yeah. This September, yeah.
All right. Well, should we wait for a little bit to make sure some people are on?
Yeah.
Okay.
Little bit, maybe some 2-3 minutes, and then we'll start.
Absolutely. We're
Yeah.
on.
Yeah.
Okay. I just so Natalie, the recital went really well. My niece did really well in the recital. The ballet.
For 5 days.
That's great. I'm happy to hear it.
She was okay. They did 15 acts, they did 15
Yeah.
dances. Their group did one, and it was 3 minutes.
Oh,
It was an hour and a half for 3 minutes.
Oh. It's worth it.
It was worth it. She was so excited. Here's my cup, Natalie.
I don't see it.
I think, yeah, I think we can start now.
Okay,
Okay,
great.
that sounds perfect. Did you want to introduce me or do you want me to start?
Yeah. Today the talk is going to be one second,
Oh, so we're talking, I'll take it over.
yeah,
We're
yeah,
talking about,
yeah.
okay. My name is Kathy Turk and I'm at Texas Children's and I did the first presentation with y'all and I'm excited to be back. I love doing these presentations. I love doing this education and I love the questions. So today we're going to talk about genetic disorders in swallowing. We see so many genetic syndromes and I learn about genetic syndromes every day and I've been there 30 years. So it's not uncommon for us to see a swallow study or get a referral from a child that has a deletion that we've never heard of that doesn't even have a name. But today we're going to talk about ones that we have a name and some that are more common and kind of things that we see clinically as a speech pathologist. So the objectives today were just basic review of genetics and terminology we use, explain feeding and swallowing patterns commonly observed in children with genetic syndromes, and identify risk factors in particular populations that warrant instrumental swallowing evaluations. Just basic genetics review. Chromosomes are the structures that hold genes. Humans have 23 pairs of chromosomes for a total of 46, holding an estimated total of 20,000 to 25,000 genes. Females have 2 X's, while males have an X and a Y. Seems simple enough, but things are very complex. Many chromosomes have 2 segments called arms, separated by a pinched region called a centromere. The shorter arm is called a P arm, and the longer is a Q arm. One of the sets of 23 is inherited from the mom, from the egg, and then the other set is, of course, inherited from the biological father, from the sperm. Chromosomes abnormalities are organized into 2 basic groups: numerical abnormalities and structural abnormalities. When we talk about numerical, you'll see, if you see a syndrome, it may say trisomy 21, or so it's when that's a numerical abnormality. Missing one or chromosome from a pair is a monosomy, and more than 2 chromosomes instead of a pair is called a trisomy. We see a lot of structural anomalies too, where you have either a deletion of a chromosome, a duplication of a chromosome, a translocation, or an inversion. Each of these will present with different physical features and physiological features. Today, I'm going to try to go through briefly each of these syndromes and kind of tell you what we see as clinicians and what we see their clinical manifestations and their physical attributes that kind of impair their swallowing abilities. The first is 22q11.2 deletion. Whoops. It was first described in 1828. It's gone through many different names: Sprinson syndrome, velocardiofacial syndrome, Catch-22, and DeGeorge. It results from microdeletion of 22q11.2, which encodes 90 genes. So that's the numerical abnormality. See, some of the features you'll see in these kids is you'll see a cleft palate, but physically you'll see a smaller head, a low nasal bridge, small eyes openings, a short nose, a thin upper lip, and a flat midface. The complications that come from having 22q mean they usually have some kind of palatal insufficiency or VPI insufficiency. The facial features start to be more prominent as they get older. They may have cardiac anomalies. They may have thymus gland dysfunction, an immunodeficiency caused by the lack of producing T cells, and autoimmune disorders. When they get older, they may have some learning problems. And I want to make sure that you know that every kid is so unique. Every child is so different. This is a generalized statement of the kids with this syndrome. they may have some behavioral disorders or dysfunctions. Okay, what do we see clinically? Oh, as we said, they're all different. So 22Q, you'll see a range of mildly affected kids and then very severely impacted. Most often you'll see an oral phase deficit, and it's usually dependent on if they have a cleft palate or a submucous cleft. If these children do have a cleft, when you're first feeding them, you're going to notice maybe food come out of the nose. You're going to have coughing and choking. So when we have kids that have an oral phase deficit or a cleft palate, we have to use a different bottle. We use a compression only bottle, such as the Dr. Brown specialty nipple. We used to use the pigeon bottle. Haberman has one too. But so these kids are very much like a cleft palate child where they can't get that suction and we need a different bottle. Unique to 22Q, unlike just a child with a cleft, if you have a 22Q 11.2 deletion, you will have pharyngeal phase deficits, meaning they may have a delay in swallow. They may have hypotonia of the pharyngeal contractures, constriction. So you see that kind of messy swallow. NP reflux because of the palate, and then occasional cricopharyngeal dysfunction, meaning that when they swallow, the muscle that should relax, the UES that should relax, sometimes doesn't relax all the way, and you have complications. You may have aspiration because of that. We're going to explain more in the detail about how to analyze a swallow in our next presentation that will be in August. These kids, which I love to hear about all of these, is that most times they become oral feeders. Maybe not initially. Maybe they need a supplemental form of feeding like a G tube or NG tube, but they do well as they get older. Okay, here is a swallow study. Whoops. Whoa. Here is a baby swallow, a swallow study on a baby with 22Q. And I'll play it for you. Hopefully it plays well. We tested it. So right here, you'll see this is the nipple of the bottle. And just to give you a space, it looks like there's an NG tube in place. And then this is the jawline. You don't see a lot here, but this would be the trachea. There's the esophagus. So let's play it and see. You'll notice that there's some nasal pharyngeal reflux or backflow there. And watch here, you'll see some aspiration right there. I'm going to play it again. I know this is new for you and you don't have to, if you can get a sense of it, I'll play it one more time. So what I'm going to have you look as here, because the child has a submucous cleft, the liquid, ooh, it's very touchy. The contrast is going to go up the nose or up right here, up into the nasal cavity. And then when they swallow, you may have a little bit come down here, which is called aspiration. I'll play it again. And there's where the aspiration is. Okay, so when we see the babies with 22Q, you're going to have sucking problems with the suck-swallow ratio, maybe being altered because if you don't use a compression nipple. The rhythmicity, this one, actually the rhythmicity was not that bad. The expression, they usually have trouble with it if they use a regular nipple. This was a specialty nipple that we used. The pharyngeal findings would be that food coming up the nose, and then sometimes they have residue in the pharynx, which would be around that area, and they have reduced airway protection. These are just so, the next slides are esophageal compressions. I'm not going to really show them, but this, oh, well, it's going to show anyway. So there is a compression right there. It's not uncommon for kids with 22Q to have a compression in their esophagus. It may be due to heart problems. It may be due to other reasons. They also may have trouble clearing that esophagus, which, let's stop this one. I don't know. They also may have trouble clearing the esophagus. So even if they swallowed okay, they may have digestive problems because look, this is a child with 22Q and they're swallowing. But you see, this stuff should be going down and it's kind of getting stuck. So that esophageal dysmotility is common with these kids. So for 22q, what I think of when I see 22q is like they're going to have swallowing issues. I'm going to do a swallow study. I want to see what nipple I can use to help feed my baby and go from there. The next is trisomy 21 or Down syndrome. This one is a more common one, and we all think of kids with trisomy 21 as the cute, chunky little, children that seemingly do well eating. Well, initially they don't because they're born with hypotonia and they really have trouble really expressing and sucking. So oftentimes they need to see us very early on to get them feeding. The genetic underpinnings of trisomy 21 is that it's a genetic disorder that has an extra, when we talk about numerical abnormalities, this would be one. So trisomy 21 is an extra copy of chromosome 21. Some of the characteristics, you may know these, but I'll just go through. Hypotonia, especially early on, the eyes slanted upward. They seem to have a flat facial profile, a smaller oral cavity. The tongue seems like it's very big. Small, low-set ears, hyperextensibility, meaning they're very mobile. They can, they just have a lot of mobility if they're more flaccid, and short hands and fingers. Unlike that things that we think about, they have usually low birth weight, and they have trouble at least initially trying to gain weight. Of course, again, as with anyone, they all vary. We have very, very, very high functioning trisomy 21s, and then we have children with trisomy 21 that have very autistic-like features. And so that would play a role in how I'm going to try to get them to eat. If I have a child that is higher functioning, I'm certainly going to push the chewing on that. And some of the ones with other comorbidities or actually things that go with them, a more severe case, I may not be able to go to the solids right away. Okay, so what do we see clinically? Again, we have a wide range of what we see. And with Downs, you have the entire hypotonia throughout the body. So you have muscle weakness throughout muscle like tone weakness throughout the body. So the oral phase would be when we first see a child with Downs, they typically have a weak sucking skills. They have reduced labial seal or that lip closure. Inappropriate tongue placement, meaning when you see a kid with Downs, you'll many times see them with an open mouth posture and their tongue may be out protruding a little bit. That gets better with time and also with speech therapy and with some of the things that we can teach. It results in reduced bolus formation because you have the reduced tongue and you have reduced sucking. So sometimes their bolus is not the best. We know that with trisomy 21, their chewing skills may be delayed. Um, it may be delayed. Whoops, hang on. It may be delayed, but they eventually we can. Most of these children go on to eat very well. It may not be perfect. It may not be the prettiest always, but it's very functional. So we have trouble because that tongue wants to go forward and protrude, that tongue protrusion. It interferes with spoon feeding. It interferes with going to solids because if you keep pushing the food out, you're not going to keep it in the mouth and lateralize and try to keep that bolus together to push it back. So with some of these children, we have difficulty finding the right drinking vessel for them. And that's where we come in. We have, you find something that maybe is a little faster flowing for these kids. Or we try like a MAM. We've tried our different positioning with these children and the tongue protrusion. And then clinically, when we try to do spoon feeding, we may not go like the traditional spoon feeding route. We may have to do a lateral placement of the spoon to try to keep that tongue in and to try to teach it different skills that it's not natural for a child that has tongue protrusion to want to keep his tongue up and move back. So I'm trying to train this child to change his pattern to make it more efficient so he can take that bolus and transfer it to the pharyngeal pharynx. So obviously there's some delays. There may be delays in their steps, but we get kids with trisomy 21 learn to eat very, very functionally for the most part, and that's a general statement. But that's due to therapy and a lot of practice. The pharyngeal phase with trisomy 21, sometimes you'd be surprised because we think of that the children love to eat and they seem to do well. But initially, because that tongue is so discoordinated and the labial seal is not there, they may have a delayed swallow and they may have some penetration, they may have some aspiration, and they may have some pharyngeal residue. We sometimes with trisomy 21 have to thicken the liquids because of their bolus control. And with trisomy 21, there's always so a sensory-based deficit is present. If you, and this is very common, if you watch children with trisomy 21, other kids too, but they may put too much in their mouth. So when they take just a bite, they don't just take a little bite, they take 1, 2, 3 bites and they still have the food in their mouth. When they do that, when they take fast bites and they overstuff, it sets them up for choking, right? And it also sets them up for pocketing, meaning they don't clear that bolus quickly. So what we do with those patients is that we give them bite-sized portions, and then we pace them until they can learn to pace themselves. So other things that may be true is transferring foods chewing. Oh, sorry. Transferred solid foods without chewing fully. So this is what I call the incomplete chew. So they chew twice, they think it's enough, they swallow, they gag, they vomit. So we may have to work on that. As far as chew, 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 we use a lot of mirrors, we use a lot of verbal cueing to chew their food to train that skill. Okay, so let me show you a swallow study with that. Okay, this is a trisomy 21 infant. Again, this one looks like has an NG tube in place. You see that tube going down to the stomach. And then there's the nipple of the bottle and there's the ear. Watch this suck. It's not a true tongue cupping and tongue sucking pattern. It's an up and down jaw excursion. When you have that up and down jaw excursion, you could see and you could tell how that would impact the child's efficiency in taking a whole bottle. Let's show that again. Watch the nipple. Whoa, this is a little picky. I don't know what's going on here, but okay. Try it again. Again, you see that chomping kind of motion and inefficient sucking. So this is a child that we would change the bottle out. This is not a good bottle for this kid. We would have to do something a little faster flowing if the swallow is good. And then we work on trying to retrain that the tongue cupping and find the right pair for the tongue and the nipple that we can use. This next syndrome is called Mobius syndrome, and it is very challenging. We don't see a lot of these kids, but when you see a Mobius child, you will know it because they have a very flat affect. They have like they don't have expression to their face because there's cranial nerve facial palsy, which is 7, and then their eye gaze, 6, abducens cranial nerve, is they can't lateralize, their eye movements don't go from side to side. So this is a typical type expression that you would see on a kid with Mobius. They may have limb abnormalities, developmental delays, and with Mobius, if it's just 6 and 7, their pharyngeal swallow is going to be good. However, some of these children have 9, 10, or 12, which we know affects the tongue and the actual swallow. So depending if 9, 10, and 12 cranial nerves are intact, we're going to find a way, and they find a way to feed themselves. They're amazing. Watch. Okay, so what do we see clinically? You're going to see impaired oral phase with oral control and inefficient feeding because they lack the facial cranial nerve for lip closure and for movement. Very poor feeding in the first year when when they use a bottle. However, the patient's moms have taught me tremendous things. They have used syringes, they have used squeeze bottles, they have used a honey bear squeeze bottle to feed the child in lieu of a bottle if they have an intact pharyngeal phase. So it doesn't mean they can't eat. It means that they really have it struggling trying to suck and swallow it initially. The volume by mouth is usually limited in early life, depending on your patient and the family. The chewing is going to be poor because the cranial nerve 7 is involved, and also the labial seal isn't there. But they can do some motion with the jaw. As they get older, most functional consistencies are liquids, sometimes are thickened, and puree foods. That's not always true either. We have kids that eat solids. I'll show you. These children learn how to cope with their deficits. So they will use their hands to help close their mouth. They will use their fingers to move the food side to side. Truly pretty amazing. As we all talk, we learn more from our kids, or a lot from our kids, just as much as they learn from us. Okay, look at these videos. So the first video is this girl has a Mobius and she is sucking out of a straw. Watch. Her lips are not closed, but she uses her tongue. She's figured out a way to do it. And this girl loves to eat. Okay, next. Now the next one is going to be an open cup, so you're going to see a little mess, but watch this. She tilts her head back. Why? Because it's easier for her tongue for the bolus. She doesn't have her lips to close like we do in that nice tongue movement. So she tilts her head back to propel the bolus to the pharynx, and then she swallows. She closes her lips with her hand. Let me show you this again. Again, pretty impressive. Okay, and this is her eating a cookie. That's, she is chewing. Her lips can't close all the way, but she's chewing. She's getting some up and down motion. She uses her hand to kind of move her food from side to side. And you'll notice with these kids the lack of expression. Many times these children are categorized. They think that they're not in a good mood or they have some other things because when you don't show a smile, um, you are judged for it's really interesting. They feel like they don't, aren't happy. It doesn't mean any. They can be very happy. They just have they can't smile. Now, there are some procedures that Texas Children's doing, other places, to do some grafting of muscles to make them smile appear more natural. But having said that, she has not had that. And it's a very intensive surgery. It's not always successful. So, but there's definitely research in that area. Okay, next. This one has charge. Uh, this is about charge syndrome, and it's really an association. Charge is actually a mutation on GHD7. It's on chromosome 8. That's found in 80 to 90% of the cases. Additional genes associated with charge have not been identified. Very rare-ish, well, not that rare, one in 8,000 to 10,000. We see a number of charged kids at our clinic. CHARGE is an acronym, and it was first described by Hall in 1979. CHARGE stands for coloboma, or the abnormal development of the eye, and they have like a keyhole pupil sometimes, and it can affect their vision. Heart abnormalities could be an ASD. There's many different heart anomalies that go with it. Atresia of the choana, very important when we talk about bottle feeding, because if you don't have a choana, you don't have a nasal, what it means is the nasal passages are blocked. Whoops, hang on. Um, so it does require some surgery, but it does affect their, of course, suck, swallow, breathe. Restriction, retardation, we prefer restricted growth. So in utero, they have a restricted growth. They're usually smaller with small birth weight, and genitalia or urinary abnormalities, and ear abnormalities and hearing loss. No longer are these features, you don't have to have all the acronym to be charged. But there's some additional features. You may have cranial nerve abnormalities, which we see a lot, esophageal abnormalities, which we depend on our GI doctors to help us with that, and small or absent semicircular canals, which can affect their hearing. And then, of course, ENT is involved in all of this. They may or may not have a cleft, 30 to 48%. TE fistula means there's a whole a communication between the trachea and the esophagus, and 18 to 29%. That's corrected at birth or after birth. Cardiovascular, 72 to 92. That's a high percentage. GI issues, 90 to 100%, and coloboma, which affects the eye. They may have cranial nerve involvement. So what do we see clinically? We see difficulty with suck, swallow, breathe. All of these have their own nuances. They all have feeding problems. That's why I'm presenting them, right? The first 2 years are tough for these kids with charge. Most of them have G tubes, typically need it. But having said that, they get better with time. So you may see failure to thrive. Okay, here is a video of one with charge. What you see here is reduced sucking here. You see the UES kind of opening, but you see aspiration. A lot of oral spillage. Some going up the nose because it's coming right there. All right. Oops, hang on. And then this would be a puree. I'll just show this one. Do you see stuff going up the nose? Poor clearance. This is very reduced right here. When we see these studies, we're like, oh yeah, that child has charge or some kind of syndrome that is affecting. Because you see all this, the tongue's not really moving great. We have some accumulation of contrast in the pharyngeal recesses. We see some aspiration. There's some going up the nose. So with these children, they typically need a G tube, but we work slowly on whatever we feel comfortable with, and then progress them onward. This next one, this is 9:30. Okay, the next one is Apert syndrome. Really interesting because this is one of the syndromes that really goes into craniosynostosis, where there's premature closure of the bones, and so you see a lot of, if you look at this child, you see the head isn't, there's hypertelorism, meaning the eyes are really far apart. You see maxillary hypoplasia, underdeveloped mid-face. A hallmark of this is the head shape. Hang on. Is you notice them physically, you definitely notice there's a syndrome, and you notice the bulging eyes, and you notice the cranium, the head misshaped. And these kids require a lot of different interventions, craniectomies. They do the posterior vaulting. They do all kinds of surgeries to correct and give them space for the brain to develop, right? Um, with Apert syndrome, they have a short stature. They also have skeletal anomalies. They may have palate weakness or a cleft palate. And syndactyly, when there's some fusion of some of the bones, and you'll see syntactly of the fingers. So Apert is a mutation found in the fibroblast receptor 2, FGFR2. Now, I think it's very interesting because depending on what is affected in that FGFR2, you may get Apert, you may get Pfeiffer syndrome, you may get Crouzon syndrome. They all have craniosynostosis. They all have need for surgeries, to major surgeries, and they all come with different complex feeding and speech issues and development issues. So craniostosis, it's a premature fusion of the cranial structures, right? So some children, most children with craniosynostosis may have hydrocephalus because of it, meaning they have the fluid in their brain. They need to have a shunt placed because they have hydrocephalus, and that can affect development too. So not only do they have to have surgeries to fix their cranium, but anytime they do a surgery comes with its own complex issues. We had one child that had Crouzon that was doing well, and then she went in to get a posterior bolt distraction to get more space in the back part of her by the occipital area. And she ended up coding. So then she had to go back into surgery. They had to do, and they found that she also had hydrocephalus at the time. So she had to have a shunt placed for that. So these are some of the things that we see them initially, we see them throughout their life at different stages. And one of the things I notice basically is if you watch these children, they will teach you what they can and cannot do, and we will figure out a way for them to try to eat. Along with other issues that of course, facial issues that you see. You have heart anomalies, you may have hearing loss because you may have kidney problems, you may have definitely feeding and swallowing, and speech and language delay. Common findings, as we see with a lot of these kids, that suck, swallow, breathe, it's really hard. Bottle feeding is so hard for many of our kids. Respiratory changes during feeding because the anatomy, just the overall anatomy that you'll see. Nasopharyngeal regurgitation, meaning food's going to come up their nose, and general feeding difficulty due to airway issues. Many of our kids with Apert syndrome, with Crouzon, will have a trach because of to manage the airway. And then chewing difficulties because they tend to have a very pronounced underbite. And if you have a really malaligned jaw, it is really hard for them to learn to chew. And I'll show you. Okay. Okay, this is a really blurry video, but I'm telling you, it tells you a lot about the anatomy. I mean, this is why I love swallow studies. Let me see if I can pause it. Okay. Um, if you just look at the anatomy up here, look at see the underbite, the palate's like, I don't even know where their nasopharyngeal space is because the alignment's so interesting. So watch, I'll play it for the swallow. I don't even think there's much swallow. Let's see. Okay. Okay, this seems like whoa, hold on, hang on. Okay. All right, let's try this again. The swallow doesn't look that bad, right? I mean, there's a little bit of residue, but it doesn't look that bad. And it's amazing that she's figured out how to get it back. And I don't even see any NP on that one. So just the anatomical differences that you see with this population, that's why I love working with them, because to me, it's so interesting to try to get them to lateralize and to get them as close to being a functional feeder as we can. So I'll play it one more time just so you can see it. That looks like puree. And it's functional swallow. I mean, there's another swallow. And if you see, you'll see a kit up here, there's like no nasal pharyngeal space. Like, okay, look, there's the palate and there's right there, the posterior, okay, the nasal pharyngeal area is like almost absent. If you see it, very small space right here. And if you see that, that would make it really hard for them to bottle feed, to breathe through their nose. And also when we're trying to do passing air valves, sometimes if they have so much congestion, they don't really love that because their nasal passages are blocked. Okay, whoop, so let's go back. Okay, this is puree. I want you to see the bottle real quick. That's puree. And she kind of tilts her head back. Here comes a bottle. Oh, nope, I'm puree. Here's a bottle. This is a specialty nipple. I mean, you see the palate kind of sticking to the tongue. It's very passive movement, but there's very little space for it to get up. It's trying to get up to the nasal area, but it's blocked anyway. So, all right. So with those kids, okay, so I want to show off some of our kids. Okay, here, this one has Apert syndrome. Okay, and this is my coworker. My colleague trying to get her to talk.
Let's sing. Old MacDonald had a farm. Tara peekaboo. Peekaboo. You want to peekaboo with her? Peekaboo.
So she's trying to talk. Okay. So, okay, and this is my patient. This is like, I just love this little girl to death. Okay, she was not vocalizing. We would put the passenger valve on, nothing. And she would point and she understands well. She would like do this, like this, no. And she would do so many things when you say, look at your mom. So she understands well, but she wouldn't try to talk at all. So here we are. We got her going now. She's saying hello. All right, and then now we know that she can do la la. We're doing a little bit more la la. Here goes. La 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 la. Okay, let's turn these off. So she's taught me a lot, this one right here, because she's learning how to lateralize and she's eating small amounts of like soft mashed foods. She doesn't like purees. She did not do well with purees. It was just a mess. And she can drink from a straw. All right, we have 20 minutes. Okay. Golden Hour is the next one. We'll go through this quickly. And this is all on video, so you can go back and look at this later. But what I find interesting about Golden Hour is they have the mandibular hypoplasia on one side and hearing loss on one side. And they have hemifacial microsomia, meaning so it's one side smaller than the other, hemifacial microsomia, and then microtia they have ear abnormalities, and oftentimes they need hearing. My little one has a Baha hearing, doing really well. They may have cervical spine abnormalities, ocular problems, palatal anomalies, which they do have most times, and facial palsy. Golden Heart is a group of characterized. The hallmark is the hemifacial microsomia. And then this is kind of telling you how its development. There's a problem in the early development of structures in the embryo, first and second brachial arches, the pharyngeal and visceral arches. We don't need to go into all this, but I thought you might want to see that. Of course, if you look at this child with this is hypoplastic and you see that it's smaller, they're going to have difficulty suck, swallow, breathe. And if they have palatal problems, which most of them do, you're going to have that inability to express the bolus from a regular nipple. They may have reduced bolus transfer, of course, reduced chewing. What's interesting, my kid that I work with, I've worked with several, but one liked to chew on the side that was weaker. And so I said, okay, this is what we're going to do. Reduced chewing and lateral movement. For chewing, I think that Natalie, they probably went over this. You really need that good lateral movement for chewing so you don't choke. You can have bilateral, but I haven't seen bilateral, but you can have bilateral involvement. And this improves with age. I'm not going to show you the video, but I want to tell you this case. So this is one of my cases. A 3-week-old came here, poor weight gain, suspected golden heart, bicuspid aortic valve because we had heart, microtia the ear, mandibular hypoplasia, hemifacial microsomia, ankylosing, and the child was a former term infant weighing 7'6", which is pretty good. When the baby came to me, baby was all PO, not gaining any weight. We used the specialty nipple because of we knew there was a submucous cleft and the suction was not good. And they were taken 30 to 40 every 3 hours, but feedings were taken an hour. So if feedings are taken an hour and you're only going to get 1 ounce, it's hard to gain weight. So we did a swallow study, and on the swallow study, it showed oropharyngeal dysphagia with a poor latch, reduced inefficient expression, reduced tongue cupping that you need, and a delayed pharyngeal swallow. We tried all kinds of bottles, and the child aspirated on everything. The pharyngeal phase, we tried a pigeon bottle. Pigeon bottle, I don't even know if anyone uses them anymore. Very fast flowing bottle. So I thicken the liquid and it really just needs compression. So it's a fast flowing bottle that serves well for our kids with Mobius, and it serves well maybe with this one. So we tried that. So here is our little guy. Well, due to continued difficulty, he ended up getting a G-tube. Mom was thrilled with the weight gain after the G-tube. She was mad that she didn't do it sooner, but I feel like with some of our parents, they have to make the decision. They have to buy into this. I can't tell them this is what you have to do because he had an NG tube. So the NG tube, we tried to do oral feeding. We tried to do NG tube, sorry. And then we said maybe a G tube because it's going to take long. Once she got the G tube, he actually wanted to eat more because I took that NG tube out. We put it in the G tube, they placed the G tube, and then he started wanting to eat. Here he is at 14 months. Okay. Cutie patootie. He has a Baha hearing aid, and here he goes. He's placing it on his weaker side. He's doing some up and down munching. He's trying to tell me something. I probably wasn't listening, but he loves to eat. Here he is with a sippy straw cup. And this is slightly thickened. He's doing great with it. Okay, so next in our last one, I'm doing well with time. Okay, then the next one is Turner syndrome. And Turner syndrome is really near and dear to my heart. My great niece, she has Turner syndrome. When she was born, she was 5'10", which is small, but the parents are small, term baby. What we noticed, or I noticed, is that one of her ears was flat in the pinna, one was flat, and the other was cupped. I thought that was interesting, but I mean, I'm just a mom. I mean, I'm an aunt, and I'm trying to take off my speech pathology hat. But what we did notice with her is that she was breastfeeding. What happened? Hello?
I think someone unmuted themselves, maybe.
Okay. Okay, is it back to normal?
Yeah, all good.
Okay,
Yeah.
good. Okay.
Yeah,
So
go
the
ahead.
last one is, okay, Turner syndrome. So she was born, she had atypical ears, right? But you know, we know your ears kind of form late and whatever. So, and she was having trouble breastfeeding. She wasn't really gaining weight, but the parents are small, 5'2" and 5'8". So she wasn't gaining weight. So I had recommended, and this is what I think, this is why genetic testing is so important. I had recommended early on, maybe at least get a GI consult because I'm worried about the weight, right? So we get into my colleagues, of course, and he said, you know, she's little, but she's doing okay. And he said, let me see her back in a month. And then we saw her back in a month, and he said, you know, I think that, and I had mentioned this to the family, maybe genetic testing. At that time, my niece said, why do I care? She's just who she is. This is what you're going to hear out there. And I get it. This is who she is. So she was now doing okay, but she's now 10 months and she's still not really gaining weight. And I did notice she's kind of a little bit like more flexible than I would think, and a little delayed in her milestones. But this is where it's critical that you bring it up at least as a clinician. Say, because of these findings and because she's now she's failure to thrive now, maybe consider doing genetic testing. I said that and I did not get well received because even if my niece was kind of on board, her husband was like, she's fine, there's no problem, she's going to be little. The problem with that is, what if you have something else with that? And so then we talked a little bit more, and I had a wonderful doctor, Dr. Chu. He recommended to my niece genetic testing might be helpful. And that is kind of what she needed to kind of say, okay, I'm going to do this genetic testing. So even though I mentioned it, it may not have been really listened to, but when a doctor says it, sometimes that helps. And then my biggest takeaway was I said to my niece, it's really not about a label because we're going to treat her the same. I don't care what she has. But what if she has heart issues? What if she has something that we need to take care of? So this is why I think genetic testing is amazing, because when she got diagnosed, we got her on growth hormones. So there's things that we can actually do to help her, and she was thrilled. But it's a process with some of these families, and I get it. So we're not forcing anyone to do anything, but we just put it out there. So basically, if you look at my niece's daughter, who's beautiful, by the way, it affects only females. They do have a webbed neck, a kind of wider neck, low set ears, a broad chest, and a high narrow palate. It's not usually cleft palate, but they may have nasal speech, and she had speech therapy to correct that. They all have short stature because it affects their growth. This Turner syndrome does. Swelling of the hands and feet, lymphedema is what they can have. Ovarian insufficiency is the hallmark. Basically, I'll tell you in the next slide, but they'll have ovarian insufficiency. They may have cardiac abnormalities, which she does, which we're monitoring. But now knowledge is power. And then hearing loss, Turner syndrome, she has very small eustachian tubes, very tiny. So they had to put tubes in just to prevent, the fluid. And so far, her hearing is good, but that can change over time. Okay, so Turner syndrome is one of the X chromosomes is missing or partially missing on some of the cases. You can have monosomy, where complete absence of the X sex chromosome on 45, or you can have mosaicism, which means you have two complete copies on some cells, and then only one copy on some. It's very, very, very interesting. And there's the next one is X chromosome abnormalities, where there's part of the X chromosome that's missing or abnormal. The last one is very interesting, and it's the one that my grandniece has. She has a little, on one of her X chromosomes, she has a little Y in that chromosome. What does that mean? It doesn't mean that you're a male. It means she has all female parts. But her chances of, she cannot conceive because her ovaries are not functional, right? And what they can have is a gonadoblastoma, which is cancer. So for her at 3, she had to have her ovaries removed. So all that said and done, there's a lot to a syndrome that is very important in just the name, right? It's everything we need to go, and knowledge is power. Now my niece is like in charge of the Turner syndrome committees, and she's very involved, and she does beautiful speeches about what she's gone through with her daughter, and she's advocating for more help in the research with Turner syndrome. And the features vary greatly, but we do know that they often have suck, swallow, breathe problems. They have difficulty breastfeeding because of that suction. They have a poor appetite. All that increases with age. Reduced chewing. Even now she's 7, her chewing is a little messy. She doesn't, always close her lips, but it's very functional, and she loves to eat. And frequent vomiting. So things that we observe: inefficient, reduced sucking as an infant, difficulty transitioning to solids and textures, frequent vomiting, reduced oral intake, gagging, expelling, she didn't have that, and pocketing, she did not have that. Typically functioning feeding over 4, they're all good eaters, generally speaking, right? And here is a video of one with Turner. This is not my niece, but again, an NG tube is in place. It's a functional swallow if you look at it. Functional, I mean not aspirating. She's protecting her airway. It's not bad. And there she is. Now she's 7. I need to update her picture, but she's doing very well. Okay, well, that, my friends, ends our little speech. And I hope you enjoyed it. If I do have this one video, do we have time to show this?
We
Yeah,
do,
sure.
go for it,
Yeah,
Kathy.
go ahead, please. Yeah.
Okay, I just want to show you, oh, and this, okay, this is a little one that's taught me a lot. He has Beckwith-Wiedemann, which Beckwith-Wiedemann, they have, is an overgrowth syndrome. He has type that one part of his body is bigger than the other side. His tongue is very big, but watch what I didn't know how well he'd do with solids, but watch this little guy. You can see his tongue is protruding. We have some like pancakes. Or muffin, sorry, it's a muffin. This little guy can move it. He can lateralize. Uh, he's he's taught me so much. He does over stuff, but that's why I do it small pieces. He enjoys eating. He's putting on each side, but if you watch him, we've actually seen him lateralize from one side to the other, which is huge in his transition to solids. And this is a big piece. This is the one we were a little worried about. There's, all right. All right. That is the end. Okay. It's 9:55. Well, I did pretty well. Do you have questions? Oops. Hello?
Yeah.
Oh,
Let's see, is
I
there
mean,
anything in the chat box? Someone has said that was a great presentation
oh, thank you.
and he loved it. Okay, that's good. Okay. If there is no questions, then
Well,
yeah, maybe we'll wind it up. Uh,
I
Okay.
have a question.
yeah,
Kathy. It's me, Lauren.
yeah,
Hi.
yeah.
Hey, Lauren.
Sometimes I think you were kind of explaining pretty nicely with your niece and um, just kind of her journey on their acceptance of getting that genetic testing and things. But sometimes I find it hard with these kids who have these genetic syndromes, like getting the buy-in from parents or to get that swallow study and you don't want them to feel like you are judging their child just based off of a syndrome, because like you said, every kid is different, right? And they kind of are. But how do you kind of counsel families and get them on board to maybe like get a swallow study or like why we need therapy and just I guess I'm just kind of wondering, sometimes it's hard at first, right, to build that relationship with them and get them to trust you. And
That's a great question.
and you're not trying to limit their child, you're just trying to get them the best assessment, right? So you can treat them properly. But sometimes I feel like there is that, and rightfully so, right? There is that kind of defensiveness or that, no, everything's fine with my child. And, I understand that, I think. But so do you have do you have a way you like to counsel, or do you have, I don't know, just any thoughts on that?
Well,
Just trying to get the
basically,
buy-in.
I think we have discussed this in like at our meetings and stuff. It is really hard when you see a child that you look at and you say, he doesn't look like the other kids, and he definitely looks, you get a feel like this kid has something genetic. And maybe you don't start there. Maybe you start with, his swallowing, he's coughing and choking. Let me do a swallow study or a fees so that we can help him reduce the choking. And maybe your step isn't, we go right to genetics. Maybe your
Mhm.
step is, let's start with a clinical, let's start with a swallow study, let's start with a fees. And then when we show the results, maybe then I take that time to kind of show the family, okay, when he's swallowing, stuff is going up his nose. Okay, we don't typically see that in our baby, so let's try to find out the answer for that. Let's dig a little deeper. Maybe genetic testing, maybe ENT. What I love about our doctors is that when we do send them to the other specialists, they will say, consider genetic testing too. It's all of us. We kind of all, and I think more than one person says it, I think it works. But it's kind of hard. In the old days, we used to get really like, you need an NG tube, you need a G tube when we saw aspiration. We would say, okay, you need a G tube. That is not the route to go because we want to respect the family. We want to bring them in the decision making. We want to give them the information to make the right decision. And we don't want to force anyone to do anything that they don't feel comfortable with. So if they don't want a G tube, let's go NG tube and let's see, oh, look, he's gaining weight now. So maybe, and that's the way to kind of to bridge that gap. But Natalie, do you have any, or Lauren, what do you do, Lauren? Because you see a lot of
Yeah.
these kids.
Yeah, I think you're right on. It's just kind of, counseling in a way that's making it more positive, right? Like, hey,
Mhm.
I'm not doing this to limit your child. I just want to make sure we get all of the information, all of the puzzle pieces so we can put it all together and help
Mhm.
your child and just be a successful feeder and be a safe, efficient feeder. So I think when you kind of put it that way and not just, hey, they have this genetic syndrome, this equals this, they're not going to be able to feed, I think,
Mhm.
and it takes time with parents too. I think like a lot of the time I have to have a few sessions to build that relationship,
Yes.
which can be hard because sometimes they can't come back in right away or, you know, so, but I definitely think everything you said was spot on. Yeah.
Well, and the other thing is like, we have kids that come in that have seen a neurologist and and they come in saying that the neurologist told them all these things that child couldn't do. And I know that's not how it was presented, but that's what the family hears. And so I always try to keep that in mind when I'm talking to my families because I want them to go away saying, my child can do all these things, but we need help with this.
Yes.
Like you said, instead of saying he can't do a million things. No,
Right.
no, we're going to say this is what he can do, but I am going to help you try to get to build what we need to work on.
Yeah.
And I think that's really how we've been trained as speech pathologists. We do a lot of counseling, right?
Yeah.
Hmm.
I think we do a lot of
Yes.
counseling.
Yeah. You have some
So
questions in the
Yeah.
chat
Yeah,
box too.
yeah.
I have a question. Hi, Catherine. This is Bhargavi.
Hi.
So,
Hi.
for some children, irrespective of genetic or any child with congenital feeding issue, if I see that the development is not happening, I use NG feeds as a tool for assessment. So, let's say I request the parents to
Mhm.
put the NG and see if there are other developments that are happening during the NG feeds, because feeding is an energy driven activity, and so that's the theory. And if there are other developments, then I counsel them further for swallow study and genetic testing, and because the child shows the outcome there.
I think
So,
that's great.
so is that because do you use it, or do we have, because this was more clinical for me, because here the parents also come from the mindset of it's an illness and it will be cured, and shifting them more towards the chronic mindset, and again there's a lot of stigma around tube feeds, and this is something I'm using and it has worked. Again, children have shown developmental progress, like social smile and all of that had come as an outcome of saving their energy through oral feeds.
Mhm.
So, what are your thoughts on that? And
Well, I mean, we all know nutrition is such an important role in development, and I think that's an interesting way to do it. We have so many different kids with so many backgrounds. We do send them to GI, and if they recommend an NG tube, they will do that. And what it tells us though is can they gain weight? What that's another thing is like if you put an NG tube in and they start gaining weight, it helped my family with the golden heart syndrome to put the NG tube in first to show them that they can gain weight. That so and then also it helped get the G tube. So yeah, I see how that would definitely would work, and it has worked with some of our kids.
Okay, thanks.
Kathy, can you see the chat box, like where people
I
can
cannot.
post?
I can barely see. I mean, I just see the screen. So what's it?
Want me to read you some of these
Yeah.
questions? Okay.
Yeah.
Okay, that was a great presentation. I loved it. Thank you. Will you be adding in more syndromes like Treacher-Collins, Pierre-Robin, things like that? Or that was
Okay,
one?
that's a great thing because Lauren, we were talking about this
Yeah.
and Natalie. Okay, it's
Yeah.
funny because we just, I mean, I've always been obsessed with genetics and syndromes and trying to help these kids. Um, Seems like that's my passion. So what I want to do within really the next year, we were talking about we have so many patients. So adding each of these for like the swallow study with them and our therapy. So not only we want to give you like what the results were, but what do we do with that information? So yes, we will be adding more, and it's a very good question.
Okay. Next question. I'm going to jump over one we can come back to, but one that I think it says, how often is the pigeon specialty feeder for cleft? I guess the pigeon bottle used to feed children with cleft in the USA, given that it is a high flow rate and has high chances of aspiration. And then like who prescribes the feeders and bottles for babies with cleft or other craniofacial anomalies?
Okay, we don't use a pigeon anymore. For our cleft babies, we don't use a pigeon. It did serve a purpose with my kid with golden heart because it just pours it because it comes out so fast, right? We have a cleft palate team, and we, as speech pathologists, know cleft palate too. So it may be one of the people on the cleft palate team to do an evaluation for the cleft kid. Well, they do it in the NICU. They do, all the babies would be evaluated by our speech pathologist. And then we see them certainly, we use, Dr. Brown is what we typically use, the specialty nipple. That seems to be the most effective and most used. We did use the Haberman, but it's such a pain because it's got a lot of parts and it's just wasn't as effective. So we've kind of gotten away from the pigeon because it causes aspiration with some, unless they have a great swallow. I don't use pigeon with cleft. I may use pigeon with a Mobius, if that makes sense. But with a straight cleft, I would not use it. I would use a specialty nipple. Dr. Brown.
And then there was also, I think there's some questions just with protocols. Like, so do we have protocols? Like also, may I know the feeding protocol for Pierre-Robin sequence with glossopexy? And I think we don't really have protocols. We just kind of, I mean, the protocol is to get speech in there to do the evaluation. Then I feel like we go based off the child, right? Was that what you-
Absolutely. Absolutely. Yeah.
Another one. I really wish that these sessions would happen sooner than just first Sunday every month. Such a wonderful thing to look forward to. That's very nice.
Oh, that's very nice.
And then there was a question, and I was kind of thinking, she said, I want to decide which bottle to prescribe for a preterm infant who's on oxygen support, and bottle feeds are very exhausting and time consuming. Will slow flow help? I think too, when we do the case studies, we can do a preterm infant who we can talk about this too.
Oh,
Who
good.
has
I think that's
oxygen
perfect.
support. I
Yeah.
think when we come back and do our case studies, we could do some more of these genetic syndromes, and then also like the preemie and this type of stuff. These are good questions, so we know what to put on that for our next talk.
And we were
But
thinking that,
Thank
to
you.
do more therapy.
But,
Yeah.
just for the time being, can I prescribe a slow flow nipple for that child? He is a 28 plus 4 weeker. He was born at 28 plus 4 weeks. And he still has oxygen support through nasal prongs. And today when I tried feed, I was there while the bottle feed was going on. The nurse was saying that it's very exhaustive for him and it takes about half an hour for him to take a half of the feed that they planned for him. So is there any way I can help him? Is a slow flow nipple helpful?
I think it could be, and I think it couldn't be. I think
Yeah,
it depends on I
Yeah.
think, sorry,
Mhm.
I'm just kind of
No,
jumping
you
in.
know, Lauren, you go ahead. Yeah.
Also, I'm curious, how much oxygen is he on?
Mm.
I think that's a huge consideration in this because Kathy, what's our cutoff for our high flow?
Well,
Was
we
it
like
100?
2 liters or less, but I mean, in the
Yes,
baby, yeah.
right.
So, it really depend on how much oxygen, what are the comorbidities of the child? I mean, and watching them, sometimes a slow flow makes it worse. Sometimes it makes it better.
Yeah.
Like you
I think
said,
my
Mhm.
question would be, is he really ready to be eating by mouth based on his oxygen requirements? Does he need more of like an NG tube and doing more non-nutritive for now? Or, yeah, like Kathy, kind of you were saying, what are his comorbidities?
Yeah, at present, he's not having any tonal abnormalities or anything. He's one of twins, and the other twin has gained weight. This child is not yet gaining weight because he also had some respiratory distress syndrome when he was born. But other than that, no tonal abnormalities, or they've not suspected anything genetic till now. But this is what I came to know because I was there only for a little time today. But I'll be going and seeing him tomorrow. That's when I'll get a better idea. I just wanted to ask about this part. But I'll keep this in mind. Thank you so much.
Yeah, I think you could try it, and just
Mhm.
kind of see. Yeah. Okay, I'll stop talking. Sorry.
No, that was great.
Yeah.
It
This is
doesn't
fun. We'll
look like there are
continue.
more questions.
Okay. Well, we will continue next, but next month we're off and then we'll be back. I'll be
Yeah,
back.
yeah, yeah.
I'll be back with
Yeah, thank you
Christine.
so much. Thank you so
Yeah.
much, Catherine. It was wonderful. You made such a difficult topic very simple. So it's going to be very tough for us to manage these things anyway. But thank you so much. Anyway, we will meet again in August first Sunday, right?
All
For
right.
the
Thank you.
fifth talk. Thank you so much. Thank you.
Thank you.
That was great, Kathy.
Oh, thank you.
Thank you.
Bye.
Bye bye.